My name's Heather McDonald, and I do know some of you, I think, have been coming to these conferences for a number of years. And today's very exciting because we're heading towards opt-out. Yahoo! But we're also very lucky today because we've been joined by the Queensland PHN, who are going to support us in today's session. And we've got Tracy and Sharon, but we've also got Christine here, who's going to give us a little, after our presentation, talk a little bit about what the consumer communications is looking like as we head towards opt-out. Now, today is a workshop. We've got an hour and a half, and we did plan to do a little bit of a workshop. Well, first of all, I should introduce Peter too. Peter and I are going to be sharing the presentation because Peter's doing the next session and he doesn't want to ruin his vocal cords. Peter's a GP from Adelaide and works as a senior clinical reference lead with us at the agency. And I put his name on there, but it didn't copy across. And I'm the Director of Education and Adoption. So today is kind of your workshop. So we have prepared some activities that we'd like you to do. But of course, if you think it's better to be asking us questions and having a general discussion as we go through, which is normally what happens at these workshops, I'd sooner do that because some of you may have some burning questions you'd like to get answered rather than do these activities because it is after lunch and if anyone's nodding off, I'll be asking you a question. Of what I've just said. So what we want to do is go through this quite quickly because some of you already know this, some of you are already great advocates for us and support us in getting the population using this system. But if I'm going too fast, please stop me if this is new to you. So, who has a My Health record as a consumer? Fantastic, you've all opted in, great. And is your practice connected? Everyone's connected, pretty much, all getting the EPIP, all meeting the requirements? No. How many of you are not connected to the My Health record system?
We're connected, but we haven't got to the level we want to in every centre.
Okay. Oh yeah, your primary care. Yeah, okay.
We're there, but we haven't got everything in place ready to roll it out perfectly.
Right. And how many practices have you got? 2. Okay. So, and you've got...
Well, we've rolled it out, but we just need more engagement at the practice level.
And update your medical director to be more current. I know, IPA. And information that you currently don't have access to provide. So foundation, so I will whip through this. Most of you know this sort of information. Because this is what's happening at the moment. Everyone has at least 4 GP visits, 3 visits and prescription. I just have to tell you, we've been working hard in the primary care space with GPs, as you well know, over the years. This year we've been targeting pharmacists to get them registered. They are a fantastic group of people who are dead keen to get registered. And we're aiming to have something like 3,000 pharmacies registered by the end of June. And we're kind of on target for that if DHS sort of don't hold up the process too much with the NASH certificates. And this is the current system as to what's happening. 20% of medical errors, incomplete patient information. How many of you spend hours chasing up patient information? This is all going to stop it. But I am talking to the converted, so I won't... and 50% of nurses' working hours are spent on basic administration. This is our strategy for the year. This is the National Digital Health Strategy. So it's not the agency's strategy. And so what's happening now is there's a whole lot of work happening to work with different organisations to see what can they contribute to the national strategy and how can we partner with them. So the big one there is My Health Record, obviously, and we're doing the expansion program now as we speak. That will be done and dusted by December. No. It'll be sort of implemented over the next 12 to 18 months. Secure messaging. Some of you may be involved in some of the projects that are happening to try to get secure messaging nailed. As you know, we've been trying to nail it for years so that you don't have different widgets on your tables. So Argos only talks to Argos and HealthLink only talks to HealthLink. We're trying to get them to talk to each other. And interoperability and data quality. When we talk about interoperability, it's about, you know, the interoperability between hospitals and general practice. It's more than secure messaging. It's about really interoperating systems. And that isn't what happens now. And in some of your hospital systems, you know, your outpatients department has one sort of system and the hospital internal has another system. You know, cancer care is a classic because cancer care has got their own sort of U-Butte system, but it doesn't talk to anything.
Nursing homes are very similar.
Yeah.
Don't talk to anything.
Well, if they're computerised at all, but you know, that's the problem, and that's what the interoperability projects are about. And there's in fact a tender out at the moment, if any of you are interested. If you're doing something innovative, have a look at the, it's on our website as well, it's, what are they called? Test beds. So there's test beds. There's some money around. If you're partnering with anyone, your PHN or anything, and doing something innovative, go onto the website and look at your test beds and see if you can apply for some money, especially in integrated care and different models of care. Medication safety. This has all been part of getting the pharmacists connected, and I have to say for a pharmacy it's pretty easy. Once the software is connected, all they have to do is register for an HPIO. They don't have to do anything because it's automatic uploads, which is different to you for your shared health summary. So they can just cruise along and not do anything. But if they want to look at a patient's record, they'll see a discharge summary that they don't get now. They'll see a shared health summary that you've put up that they don't see now. So for them, there's a lot of benefits with very little work, unlike general practice, which we acknowledge does most of the work initially. Advanced models of care, that's enhanced models of care, just what I was talking about. If you're doing something, you know, see if we can give you some funding for it. Workforce education. This is across the board. We need to make people digital ready. So in undergrad programs, we're starting to talk to some of the, do lectures for the universities. We're trying to start getting it across the curriculum, get it in the medicine schools standards. Because people have to come out ready to look at health digital literacy. Most people are born on a smartphone now, so it's not a problem, but it's about what do they do with the information and how do they send it up? Like, how do they curate their information to share? So it's about sharing information. Of course, everyone's been sharing information on Facebook from the time they're about 2. And then Facebook share their information to everyone. And driving innovation. So we need to drive innovation. And that's about, there's a lot of people now developing different apps, different programs to link into the My Health record. So when we developed this in 2012, some of the documents, they look really clunky and old now, which they are, because we're talking about 6 years in digital land. It moves so fast. So what we're trying to do is make sure that we're partnering with innovators so we can up all of these. Am I still going, Peter, or is this you?
Tag team. Yeah, I'm just going to spend a little bit of time just going into the bowels of what the My Health record is and components and everything else, and Heather will round off with some of the legislative components, privacy issues and all that sort of thing. So I think the key message about the My Health record, it's a consumer's record. It's a repository of a range of key summary information that gets deposited, so to speak, in that record and made available at point of care whenever the patient turns up in general practice, hospital, pharmacy or wherever. The key thing is not a communication tool. It assists obviously sharing of information, but it's not a point-to-point communication tool. So you still need to send referrals directly to the specialist, scripts to the pharmacy and that sort of thing. One day it may well have an integrated platform to sharing all that, but at the moment it's not designed for that purpose. So the key components of My Health record, the first bit is what I've just stated. The next, it's a national system, so unlike Apple and Amazon and Google, who have been trying to get a personal health record up and running, they're not national, okay? They're corporate focused. This is at least a national program. Every Australian has access to it, and there is some accountability and transparency about that, as well as where the data resides and who can use and access that data. It's personally controlled in the sense that the patient is obviously is in control of that record. Very important aspect. And other countries like Singapore, Hong Kong, There's no patient control. Information is just shared freely between providers. A similar sort of system, but there's no consumer control or consumer access, or very minimal access. And the thing about this, as long as IT systems are up and running, it's available 24/7 anywhere in Australia, and in fact, technically on your app, on a mobile phone app, you can access your record anywhere in the world. And I'll talk about that a bit later. And I'll leave it to Heather to talk about the huge legislation, protection and security processes that wrap around the record. I think I said that. Now, the key components of the record are the provider documents, which I'll come to in a little while. There's a whole lot of Medicare documents, which initially was seen as important documentation because there was nothing else going up. But at least by looking at an MBS claim, you could see they went to see a urologist, Dr. XYZ. PBS, you knew what medication was dispensed to the patient. If they had an organ donor arrangement, they can upload that information, as well as immunisations, which initially from the child immunisation record, now it's the Australian Immunisation Registry. And finally, the other component is the consumer entered data, and that includes for them to upload their advanced care directives, who the custodian of that advanced care document is, personal health summary, really only two components there. They can upload in a sort of structured format medications that they're on, usually over-the-counter medications, as well as any other allergies, and might be seafood allergies, to complement maybe what might be in the clinicians who will probably more likely to have medication allergies. Okay. Some of the foundation component you need to be aware of, and no doubt all of you, for those who've got a record, know you've got a 16-digit identifier. As an organisation of practice, you've also got a 16-digit identifier for the organisation, and each APRA-registered clinician also has a 16-digit number. And it's these three things together that locks in the key players in the process and locks out other players, such as private health insurers who may have an interest in this sort of data, but they're legislated not to have any access to that information. That's important to know. Okay. When a consumer visits any of these particular providers, I've just selected some of the key ones there, then a general practice, for example, is able to generate a shared health summary. If they're the usual GP practice that looks after that particular patient, or what we use the word nominated GP, if they go and see another GP or an after-hours GP, then they're more likely to generate an event summary. Because a particular event might have been laceration and given a tetanus shot, and they would generate an event summary. Hospitals, obviously discharge summaries. Specialists would generate a specialist letter. Pathology and DI, their reports will be uploaded. Allied Health can obviously at the moment upload probably an event summary, although I think we should be looking at something for the Allied Health as a specific document type. Pharmacy would be uploading all the dispensed, and aged care as well as connected. They're connected to have a look at this, obviously, but in terms of producing documents, it all depends on whether they've got a conformance system connected to the My Health record. The only other thing I would like to add there is you see the medicines prescription and dispense records. The prescription component will come from when GPs, specialists and other clinicians who have got prescribing ability, that information is also captured. So from a medicines point of view, you've got the prescriptions or the prescriber document, you've got the PBS document if it was the PBS medication, and then you've got the dispense information. And the reason I highlight these three because we have a landing dashboard that when you open up a My Health record for a patient, you have a medicines view, and it uses information from all those three, as well as any other document that might have medicines information, such as a shared health summary, discharge summary, or an event summary. I'll come to that in a minute. Shared health summary, this is what it actually looks like, and obviously it can be rendered differently depending on what interfaces we develop in the future, but at least it's got all the components of the shared health summary, and the important thing is that bit in your right-hand corner is all the audit trail information that says which organisation uploaded which provider and which patient we're actually identifying in the process. This is the medicines view. There is another one. Let's just no, it's not there. Okay, a medicine's view. What landing page will have is all the allergies from every document we can garner the allergies from, including the consumer's personal history that they've entered about their allergies, all the medicines that they've ever had prescribed, dispensed, the last shared health summary, and the last discharge summary, if there's one. And then it presents, when you go to underneath the medicines, it will have a chronological list of all the medications this patient's had for the last 2 years, as well as an alphabetical list. And you can start to see what the patient is actually taking, rather than what's prescribed versus what's dispensed, and whether, even if prescribed and dispensed, might be 3 months old. In other words, they probably haven't been back to take their blood pressure tablet for the last 2 months. That's what it looks like on the portal. This is just samples of diagnostic and pathology imaging. The key thing here is that you can open up the report from a chest x-ray or pelvic x-ray and actually read the report. And in all of these documents, if you've got a conformance system, you can not only view, you can actually download those documents into your system as well. So at point of care, if you want to keep track of what was done, you can have a copy for yourself as well. Yep.
Just about all of the public system in New South Wales is uploading pathology results. I think there's one small area, maybe in the North Coast, isn't, but it's about everything else is. Diagnostic imaging will be uploaded, I think, by the end of June in New South Wales. Queensland, passive DI public will be, I think it's sort of towards the end of this year, or definitely done sort of in the second half. And so all of the states are starting to do that. Sonic, we're doing a project with Sonic with Sullivan and Regulators, part of their private uploading. We're trialling it in North Queensland in a few practices. And you've probably all noticed, if you're on your request forms, there's a bit that says there,
do not send.
Consent, withdrawal of consent to upload. So all of the softwares across all of general practice now has that. So if you're printing off your request form, you'll notice that. And what that is if you or the patient decide not to upload a pathology, you need to tick it. And it won't go up to the system. And you know that once the pathology is uploaded to the system, the patient has 7 days before they see the result. So you as the clinician can see the results straight away. So as soon as it's uploaded, you can view it. But the patient can't see it for 7 days. And they'll see, when they go into their record, it will be greyed out. So they will know that there's a result gone up, but they won't be able to access it. So you as the practice have 7 days to ring somebody who's concerned that you don't want them to see it before you talk to them. And that was decided in 2014 by all of the colleges, and there will be a review of that process before the end of this year.
Yep.
And if anyone's interested, we've done 2 webinars on pathology that are uploaded onto the Digital Health website, and we're also doing 2 more webinars, one at lunchtime and one at night, on the 30th of May. And we've got, I think John's doing one and a project manager, and the last one went for an hour because there was about 45 minutes of questions. So it's actually quite a good one to go to because all of your questions will be answered because there was every single question under the sun asked. So it's very important because this is going to be a game changer because people who don't normally get pathology results like specialists or allied health will be able to view those results for patients.
I understand that it's downloading the report from the diagnostic imaging. Is there a plan in the future to actually download the actual images?
No, what will probably happen is there'll be a link to where they're stored. You know how
Yep.
all the states
There'll be a URL to the laboratory.
And some of them are coming in with URLs.
Yeah, they're already coming, but you still need to be able to get a password and everything to get in, obviously. But yeah, so yeah,
They're too big.
yeah.
So we did do a pilot with Monash and work with them to try to work out how that might happen. So there's a little bit more work to be done, but that's what we're hoping is that we're linking to wherever it's being stored with these big providers particularly.
Yeah.
Any other questions about it? Sorry, I'm bumping.
No, no.
It's just important information that I think we
We haven't got here, but we need to.
Yeah, there's a question at the back. Yeah.
So they will still download to a normal practice software, because currently ours are downloaded to there, but we then have the ability to upload them on a shared health summary. So will they double up or?
Upload what? The imaging, the pathology?
Yeah.
No, you shouldn't attach any imaging or pathology.
Yeah, well, that's my question. See,
Yeah.
we currently can, because when we transfer.
Yeah, they can put it on.
Oh, best practice. Yeah, I know, but that wasn't the intent of a shared health summary.
Yeah, but the other thing
Or-
is, at
yeah.
the moment, they're in PDFs as well for the My Health record, because pathology people don't want to do a top data because, other people can look at them. Pathology labs report differently, as you know. They're not even got that together, there's no standardised reporting. So they're the things that we have to work with them to try to get happening down the track. So at the moment, that's why they're PDFs, not atomic data, but we're hoping to get the atomic data coming up.
So why would you not use them as part of your shared health summary?
To upload a diagnostic imaging report. You can only do that in best practice if you're lucky.
We can do it in Genie, and the thing is.
Yeah, Genie is another one. Yeah,
we don't
but
accept any-
But that's not the intent of the shared health summary, which I'll explain in a minute what a shared health summary is. I think the important thing is you will never find it again. If I'm going to go look at my health record, the last CT scan you did, I'll go to diagnostic imaging, I won't be going to shared health summary. I won't be going to an event summary. So you've got to look at...
Transfer patients from one practice to another, that's how we do it.
Yeah,
And then they download it, so it's quite a useful tool.
you can, yeah. But it's not the intent of, again, it's not really what the original purpose of... Yeah.
It's useful for the patient themselves, why not?
Yep.
The only other thing is if you've got hundreds of attachments, you don't know which one belongs to which, because they're not wrapped.
Yeah.
That's a technical term, though.
Yeah, the metadata, there's no metadata around it, so you have no idea where to find information. That's the problem. So we'll get to that in a minute. The important thing, I think, is that once pathology, imaging and dispense, these are all automatic updates. Having that information available, everyone will be interested in going and have a look. Shared health summary is a bit of a unique animal from my perspective, because it's one that is not necessarily automatically generated and uploaded. Often involves a little bit of intervention from the GP and the practice nurse and other staff to make sure that it's curated nicely and everything else and up to date. So in the first instance, it may take a bit of time to get that right. My view is that it should be right anyhow from the start, or get it right as soon as possible, because the next time you change a medication, add an immunisation or a new diagnosis, it's done and it's one click or two and it's up, and maybe one day it'll be automated, just like dispense is, and pathology and imaging. It just simply goes up after a consultation where the summary information has been changed. We're not there yet,
It's on the backlog.
but it's on the backlog. So demographics, obviously your frontline staff, practice manager, reception staff want to make sure they've got the right demographics for the patient, that quality of that data. A medicines list often does require a GP to have a look at all the list of medications, but as a nurse, when you're doing a care plan, you might note that the patient's not taking this anymore or stopped that some time ago and it's still on the record. Feed that back to your GP and get them to clean that medicines list and keep it as current as possible. Same with the diagnostic list. You don't want shared health summary being uploaded and have in there patient recalled today, phone consult, all these things. That's not diagnosis, okay? Came in with a headache, that's not a diagnosis, symptom. And unfortunately, a lot of systems are being, and that's probably the most contentious area in data quality, is the list of diagnoses. And the way different vendor systems have allowed other things, administrative things, or a progress note, reason for contact, to end up in the diagnosis list. It's a bit of work, and every GP I've spoken to is just make sure the diagnosis list is just for that. If you want a reason for consult, that's in the progress note as a headline. Don't confuse the two. Allergies, very important to try and tease out allergies, but patients often have non-medicines allergies. Very important to also record those. But if you don't, as I said in the patient health summary section, they can add other allergies that they're allergic to. And finally, immunisations is probably the most accurate bit, particularly because nurses are doing that and they enter everything, batch number and everything else. So everyone's got a role to play in keeping that data quality happening. And it's a bit of a process, but certainly I think from a nursing perspective in a practice, when you're doing those health assessments and care plans, that's the time when you're looking at that information and you can pick that something's not right. Some of it you can fix and some will need a GP to verify that that is the case. Okay, so I mean the key benefits, obviously having information available at your fingertips. You can imagine an ED department, someone who doesn't speak English and is a little bit confused, being able to go straight to My Health Record and have all the information about this person up to that point in time will certainly assist you getting a much better history and better focus on what you're looking for, saving you a lot of time. It saves a lot of time for patients to have to repeat all the medications that they're on and diagnoses and everything else. It complements your local record system. Now, for most GPs who've got a fairly stable practice population, they probably have got most of the information about that patient, but patients do travel, do go other places, and this will complement the information that's available. And it's an important thing is about keeping it accurate and up to date, and if we're all focused on that, to me, I see as a GP, it's my professional duty to have a health summary that says accurate and up to date after that last point of care contact consult. Simple as that. That's not to do with My Health Record, Medicare or anything. It's just my profession. Just like a mechanic wouldn't half tune your car when you visit them. You know, you expect the full Monty. Okay, very important. Okay, just summarising some of the key benefits. Obviously, avoiding adverse drug events, as Heather showed in that earlier slide. You know, 10-20% of admissions are drug interactions or people giving things that they're allergic to, costing $1 billion or more. Getting the patients engaged. Now, the 7-day rule, I just want to make a note about that. It is coming up for a review. My view, I was, in a lot of places in the world, there is no delay. It's the patient's information, it's their information, and they should be able to access it whenever it's available, the minute it's uploaded. For example, an INR, a HbA1c, right? How's your cholesterol going? Why do I have to wait 7 days to know what their INR is? You know? So there's some things that are sensitive, that may need a delay, but there's a lot of stuff that should be non-delayed. And it's about getting them engaged in the process. Linked to improved outcomes, we talked about reducing, and the other one was reducing duplicate examinations. CT scans are a good example. Once you've done 3 or 4 CT scans, your risk of cancer now is escalated. But if I don't know how many CT scans you've had in your life, but in My Health Record, certainly from this time onwards, when you reach 4 or 5 CT scans, you probably think twice about doing the CT. You might do an MRI instead. And finally, just a quote from Chris Moore. Maybe some of you know Chris in Adelaide, and he certainly just nicely articulates how much time it saves him as a GP by having access to a patient's My Health Record. I might hand over to you now. Actually, I'll just finish off. I mean, it just benefits, again, the same thing. These are the apps in the corner. Who's got a Health Eye app or any of the other eye apps? Okay.
Yeah, I'd strongly recommend you, if you've got patients that are going to hospitals or somewhere where other people aren't using the system, I'd strongly recommend that you get them to download an app. There's an obstetrician in Cairns who loves this, and she got all her patients to use Health Eye, and they go to their hospital if they don't look at it, they just print it out and show them. She uses an event summary for all of her antenatal visits. It's fantastic.
Yeah.
What do you mean? Sorry.
How to get so?
What do you mean?
So you go to.
What are these apps?
These
Okay.
apps are linked to the My Health Record. So if you download these apps, you then, the first time you go on, you put your MyGov details and all of those things, and then from then on in, you just need a PIN number to access your record.
Can you not access your My Health Record by the MyGov app?
You can, but you still need all your codes, don't you?
Yeah, but I guess you're still waiting for a code for that.
No, it takes seconds. So once you download, you go into MyGov, that authenticates you, and then you set a 4-digit PIN. So now all I got to do now is do that. I've done mine. It's just face recognition. I don't even have to enter anything, and it's done. 2 seconds, and there's my record. And you can air print the documents that you want. A lot of country GPs in South Australia are recommending this to patients because when they come into the city, South Australia is still behind the 8 ball. We don't upload many discharge summaries or do much in the public system, whereas at least the shared health summary is on the patient's app and they can just show the hospital doctor what they're on.
Why are there so many apps? Why can't I just one?
Because there's different developers that are trying to do it. You know, everybody's a startup, everyone's got an app.
Yeah. There's a particular one on, there's a child health one.
To get into the system, of the API process for anyone who does want to go in there. So these have all passed it. They don't store the data, they just go in and get it out. There's legislation around it, so it is closely monitored. There's probably another dozen that want to get in that couldn't. So, you know, and you will see more and more coming in for different reasons. You know, there's the medication one that I think is working on doing something, sharing the meds. You know, what is that called? Meds something. They're already sharing between GPs and pharmacies. So now they're going to try and hook up here to make it even more convenient. So it is convenient for patients to have an app.
So do they all have the same functionality though? All of them?
No, all you can do is view. They don't do anything. It's just
You can just look, yeah, just a view, but you can print the document to an AirPrint.
It's not like going to the consumer portal where you can set your privacy conditions and all that stuff. It's quite.
So the idea is that they take along and show the allied health person here how to.
Yeah, yeah.
Is there any plans moving forward given the benefits that you've got on there? Your next slide says, you know, about benefits to chronic disease management, people with chronic diseases and complex conditions. Is there a plan moving forward to have the shared care plan summary with these sorts of, you know, like, so whether it's, you know, Medicare or CDMN or whatever, to actually have that shared care plan, the static version of it
Yep.
uploaded?
And look, part of the work plan this year was to review those care plans to try to come up with something that would be sensible, because the healthcare homes have said that all of their patients have to have a record, right? So they're all getting registered now to be part of that healthcare home. So they're all going to have a care plan. So we did start looking at some of that work. The expansion program has taken over a lot of our work, but it's definitely on the plan to review that. But to get a shared care plan that everybody was happy with would take some time, I would suggest.
Heather.
Well, it's more that you know, when you in the healthcare homes in particular, when you've got a shared care plan, and that everyone's got one, and also all other people who've got 721, 723s who've got a care plan of sorts, that, you know, there's a static version of it that, you know, it's been signed off on and submitted, so that would be quite useful for people as they move through the system.
Look,
Yeah.
Upload that as an event summary?
You can attach it as an event summary. Again, if you've got to be looking for a care plan, you may not go to an event summary. You can, what I would suggest to some GPs when they do a shared health summary, you've got a list of diagnoses. I know it's not meant to be a diagnosis, but I would write care plan, and in the comments section, because comments is also uploaded to the shared health summary, just name who, you know, podiatrist, physio, whatever, so that if they go to a hospital in ED who might think, geez, you need to be a bit of, oh no, there is a care plan, and you've actually got these 3-4 key people involved. So I'll leave that with the GP to manage the care planning coordination, and they'll do whatever hospital services they want to bolt on to that process.
As I said about the technology improving so much, things will be developed quite quickly. Like the clinical document architecture, which our documents are in now, is a bit clunky. I mean, fire and those sort of things are around. So there's people looking at all of that stuff in the agency. So then if something's developed, we can change it and be a bit more agile, if you know what I mean. So, but I have to say at the moment, the expansion is taking a bit of time and focus.
Talking about the expansion, if you want to.
So I just wanted to ask, so when healthcare homes, so by November this year, they're to have that shared care planning tool up, is that going to be the same one that's going to be in this, or are we going to be faced with two different things and try to work in two different?
No, you're going to have a shared care
planning tool,
which is your CDMnet or your Ocean Informatics or whatever they're called, those, you know, different ones. And this is this is different because this is national, and they'll have a shared health summary, and then they'll have the care plan that's shared between their immediate provider team.
So the shared care plan that Healthcare Homes is going to get us to do,
Yeah.
will feed into this.
It all depends. It's a very complicated architecture, but one scenario might be, my view, this is not the agency's view, is you've got care planning platforms, CDMnet, LinkDHR, there's a whole range of them there, they're platforms. Imagine them as a diagnostic provider who provide a care plan and a platform for sharing information and communicating stuff. And if I'm all I need to know is that there is a care plan. It might be that we upload a thing that simply says a care plan is available, here are the key players, right? And here's a URL into CDMnet. And if you want to poke your eyes in there and see all the transactions that are happening, fine. But then, yeah, because imagine that's a dynamic care plan that's going to be updated every instant someone adds something. That'll just clog the system up here, and it's probably not meant to be the place where you go to see every minute by minute change in the care plan. So it might be something, my view as an option, is to link into the care planning platform. And again, you just need a password and the consent. In this case, you'd need the consent of the patient, because they're already consented for who can be the community of carers or providers in that care plan. And I'm an ED doctor and I want to have a look. I've got a URL, I just need to somehow either break glass or, you know, whatever the system, that's to be articulated. But it might be that's one way. Another way is a static care plan, a care planning document type, but that's only as good as when it was last updated and uploaded, and it's not necessarily reflecting what's happening on the ground. So it's an important one, and as Heather's alluded to, it's actually been on our radar, or certainly even when I was in NETA days.
No, yes, we were going to wrap it and keep it with an event summary.
Yeah.
Because one of the other things is the My Health Record system is only a copy of what you've got in some other system. So that's why you can't write to the portal, to the provider portal. You can only view. So just always remember that. So that's just a copy or a summary of what someone else has got for people to share, so that you don't have to fax it.
So it's really, when we're saying shared care planning tool, we're talking about two entirely different things.
Yeah, you're talking about a dynamic tool that the physio is going to write into, and yeah.
Right.
But I think, no, but the idea of having a URL to have a look at it is a really sensible approach. But so that's why you can't write to the portal, because it'd be original notes there. And the idea was not to do that at this stage. So the expansion is going to be an announcement any day now as to the date of when people are going to start getting a record. So the expansion 12 months ago, in fact, was in the last budget. And the goal is for all Australians to have a My Health record unless they choose to opt out by the end of 2018. And here we are halfway through 2018. So I'll talk a little bit about what it means for us. But at the moment, we've got about 5.7, nearly 5.8 people who have chosen to opt in. People are still opting in, and if you're working in practices, thank you very much for continuing to opt in patients, because it's a fabulous opportunity for patients to actually get an understanding of what's coming. It's also, once they've got a My Health record and love it, they'll be telling their mates and family about it. So keep registering people. I was hoping to get to 10 million, but I'm not going to. But I did get an extra million this year, so I reckon that's pretty good. Thank you all for helping. So we have got to 5.7, nearly 5.8. But what I wanted to talk about is, see the shared health summaries. We're starting to get, what are we up to? Nearly 1.6, I think that's it.
Yeah, 1.7.
Nearly 1.7. So we're starting to get some information in the system, because everyone's complaining there's nothing in the system. 1.7 million shared health summaries is it's a good start, and the same sort of discharges. And as you know, most of the country, public hospitals and some of the privates are all uploading discharge summaries. So once everyone's got a record, that's going to be huge, because they're automatically going up. And in a lot of the hospitals, I have to tell you, the doctors don't even know they're sharing their discharge summaries, which means they have to be a little bit more thoughtful about what they write. I met a mother and she said, oh, I've got 4 kids with chronic disease. I love the My Health record system. She said, but you should see what some of the doctors write about me. I said, oh. So if anyone's doing any education anyway, just tell them, will you? And so you can see we're getting a lot of more, you can see the pharmacies is growing. 1.8. Now, not all of those are uploading, but I have to say 800 would be. There's probably 1,000 that were registered in the old days that need to be revisited. So you can see the numbers are going up, which is good. And so in the trials, there was only an opt-out rate of about 1.8, 1.9%. And since then, there's been about 3 or 4% opt back in. So if you've got patients and they choose to opt out during the opt-out period, which I'll talk about, you can say to them, it doesn't matter if you do opt out and then you want to come back in, you can. It's not a problem, you know. So it's important that people know that they can opt in and out as they please. So what's going to happen? What's going to happen is Greg Hunt's going to make the Minister is going to make an announcement in the next week or two and say, you know, from a certain date, the records are going to be created for patients, for consumers, for the population. So there'll be a 3-month period where records will be created for everybody, or the 20 million that don't have a record. Now, during that period, people are going to ask you in your practice, how do I opt out? What's this about? All of that sort of stuff. So you're going to be saying, well, you know what, don't opt out because it's really useful, and tell them the benefits. And if they're worried about privacy, which we'll talk about in a minute, there is privacy things they can set up on when they go into their consumer portal, and I'll talk about it in a minute. But that's the sort of thing you need to help your patients with. But if they're definitely wanting to opt out, there'll be a phone number and there'll be a website they can opt out on. You, as a practice, do not need to opt anyone out. We asked you to register them, opt them in. We are not asking you to opt them out. They can opt themselves out. In Queensland and Nepean, North Queensland and Nepean, where the trials were, a lot of people phoned because they didn't want a footprint of their evidence that they were opting out, because mostly they didn't want the government to know who they were, which is fine. So a lot of people phoned up. We've taken over the call centre. The agency now has the consumer call centre. It used to be in DHS. So it's all being ramped up in preparation. And this has to happen before, you know, the opt-out is going to be sort of July, August sort of beginning time, and it will start then.
The record creation?
Yeah. Yeah. And it'll be, you know, we've been waiting for Minister Hunt to announce it for probably, how long now? 3 months maybe?
You've got to stand on the videos.
Yeah. So everyone will have it. So really it's just expanding on the existing program. And people always ask, what about the old people, the elderly who haven't got computers? If they're not concerned about it, it doesn't matter whether they access it or not, as long as their providers can access it. That's the most important thing. So they don't have to access it. And there's a couple of other things. I'm not sure if we've got a slide, but say I've got a mother in Perth and she's elderly and going to lots of doctors. There's 5 of us kids, so she can say, well, you can all have a look at my record after I've gone. I don't want to look at it, but you guys can. So she can tell us that we're her we're her nominated representatives. So we can look at her record, but we can't do anything with it. Whereas an authorised rep is the legal guardian. So if I had the power of attorney for her, for example, I could be her authorised representative. So when you're talking about someone who's, say, a disabled person, and someone says, who's looking after their My Health record? Whoever is looking after their health now. So whoever the person is that says this person can go and have an operation is the same person that should have control of their My Health record. So nothing changes in that respect with ownership and authorisation and legal entity. You going to ask a question?
Is that right?
Yeah.
So when this starts, will there be some resources come out? Because my thoughts, the most sensible thing would be for us to let everyone in Medicare.
Yeah, Christine's going to talk about the comms and what's going to be happening, but there's an enormous amount of... Yeah, there'll be lots of papers to hand. In fact, every GP is going to get a pack.
Awesome.
A pack? How exciting can that be? A package of communications. So I just talked about this. The PHNs we're partnering with and doing an enormous amount of work with. They've employed specific, and Christine's one of them, communications people to engage. If you want your consumers to have a workshop or anything, just let your PHN know. Say, you know, the local probers group wants to talk to you or something. Get as many people involved as possible, because it's all localised communications. It's not a national campaign. There's no letters going out. From the trials, something like 40% of people opened the letters from Medicare, the government. 40%. What a waste of money if we did that for 25 million. I mean, it's just, we couldn't justify it. So, and also the national campaign, people turn off on, they want local ads, they want stories in the newspapers. If you've got patients that have had a good story because you've given them a shared health summary, they've gone to the local hospital, you've saved their life because you had their allergies, tell us. You know, get those stories to us because we need them, because that might help other people decide to get a record. We need your help. Okay, so this is, Christine, you're going to talk about this, I think, aren't you?
Yeah, I'll talk a little bit about that.
So this is sort of everything that we're going to be doing. So the agency's doing this, shared responsibility with the PHNs and the delivery partners. So we're working with jurisdictions, clinical peak bodies and consumer peak bodies and PHNs because we want everyone to get the message. We have to tell 25 million people that we're going to have a record of theirs in our system. So we have to try, everyone has to know this, and this is why we're targeting providers now, because providers can help us by telling the patients when they come in and ask questions. So we're hoping to get the message out at least 3 times to each provider. In fact, APRA, your registration body, will be sending you a letter in the next month or so to tell you about the My Health Record system. How good's that? It's the biggest mail out from APRA ever. They're going to email, I don't think they're posting the letters, they're emailing people, and we're talking something like 700,000 or more healthcare providers will get information out, which is fantastic. Okay, so you probably know all of this, but I'll just quickly tell you because people are probably asking you these sort of things. And I think as we ramp up, you'll see stuff in the press. And it's important not to always believe what you read in the papers, particularly the Murdoch press. I didn't say that, did I? The My Health Record can only be accessed by somebody who's involved in their care. Now that's how the O and the I link together. So just because I'm a doctor working in a practice down the road, I need 5 pieces of information about everybody that I'm going to be looking at. You all know this. You know, I need their Medicare number, I need their first name, their second name, their surname, their date of birth and their gender before I can get an IHI. So to look at a record, I need an IHI to start with, and then I need to go into the My Health Record system. So, you know, and then I have to be linked to an O. Like I'm a registered nurse, for example, but the agency doesn't have an O, so I can't look at anybody's record, even though I've got a HPII. So that's why when you read in the paper that every healthcare provider can look at everybody's records, that is actually not quite true. So that's how it works. The security system is between the link of the I and the O. And so, you know, and the same as, sure, the pharmacist can look at your record if they're delivering you care, and they might want to look at your shared health summary to see what medications you're on. But, you know, really, are they going to look to see what sexual health diseases you've got? You know, just because they know you? That's very unlikely. And if you don't think they should have looked, you've got an audit to see who's looking where. So if somebody is looking at your record that shouldn't, I mean, you can see. So they're the only people that can see it. And you've got a record of it. So that's important to tell patients, that just because they know the doctor who lives next door to them, they've never been to their practice. They're never going to find their shared health summary. They're never going to find their records because they're not registered there. Ex-partners, same thing. You know, they can just block things. Patients can see who's looked at it, and you can control. And I think you all know this, that you can put a code on a document. So if you've gone into a hospital and you've had some sort of surgery you don't want to share, you put a code on that document. So the only people who can see it are those people that you want to see it. You work at the local hospital, you can put a code on that hospital. So no one in that hospital can look at your documents.
When you say you can put a code on it, who's the you? The patient or the doctor?
The consumer. You go into your, I think we've got some slides as to how you do it. You go into your consumer portal, and there's a whole lot of privacy things. It's called privacy up the top. We'll have it on the booth. We've got some, I'm getting some flyers that weren't there, but I think they're coming over this afternoon.
Is it really something that at an emergency level that they should be accessing then if it's not the
There's an emergency, there's a break glass. The only time you need to break the glass is if there's codes. Because if there's no codes, you can see everything. And if there is codes, you can break the glass and then you see what's under the code. And bear in mind now, you've got nothing. So it's better than what you'd see now.
The only thing is if you, as a consumer, hidden the document, that's not visible to anybody anytime.
Yeah, you can remove a document. We're calling it hidden, but it means you can take it away. But you can't take your shared health summary and you can't take your advanced care planning. So you cannot delete those documents. You can delete everything else, your discharge summary, your event summaries, but you can't do that.
Can you change your advanced care plan as a person, not a health professional, as a patient?
As a patient, you can take it away. If you own it, you can take it away and upload another one. So these are the legislation and the acts. If anyone's interested in going to read them, good luck. Just so that you know that there is legislation. And, well, what's also important is the notifiable data breach that has now become mandatory as of February, but the Health Records Act is also a mandatory reporting. So they're both similar. I think it's S73 or something, is it? There's a number. So there is a mandatory reporting. So if you've, and you'd all be across the notifiable data breach, you've probably all been talking to your insurance people. So it's in here as well. So you either have to report to one or the other. And the notifiable act is if you've already reported with the My Health Record Act, you don't need to report to the other. You have to do one or the other, not both. So it's protected under the Act, and it's exactly the same as current legislation, privacy. You all follow that in everyday practice. It's no different. So you just have to know your responsibilities, which you have to know for your accreditation. Yeah? Any questions about that? So there are mandatory requirements. And the RACGP has got quite a lot of information if you need to go on there, and you need to have some policies. And, you know, by following these, you're actually helping your accreditation because you can actually demonstrate that you might have done this and, you know, how you have to show evidence of meeting these requirements. Security, look, we've built up our team in the security. We do a lot of penetrated testing. They do a lot of looking for extra activities. The security team do it. If anyone wants to work with their PHN, we've got security team that are coming out doing education. They were at the Gold Coast last night. Over 90 people went. So just if you want that sort of education, talk to the PHN and we can organise for a specific security and privacy sessions. Everything has been ramped up. We've changed platforms within the Digital Health Agency so we meet all the requirements. And all of government have got quite a big security, as you can imagine. So these are all things that you have to do in your, you know, not share passwords, don't put the password out on the front desk so everyone can look at it, all this common sense stuff. But when it's all said and done, probably safer than the fax machine where people are looking at everybody's records, or can look if they wish, you know, and the receptionist is the neighbour of somebody and looks at their records. So let's, you know, think about this. And often I think the national system may well be safer than your own system security of the smaller general practice. Not always, of course, but and the record access codes. And once you've got the code in your practice of a patient, it stays there, I think, doesn't it, Peter? So if a patient gives you the code to view their record, they don't have to keep giving it to you. It comes up when you open their record the next time. And there's very few people that have put codes on at the moment. I think it's less than 2%, less than point. I think they're probably all agency staff. But I think as we roll it out and encourage people to use the privacy, you know, if they're concerned about privacy, put codes on.
From a national perspective, from the agency, there was a consultation program probably at the end of last year about sharing data. What we were talking about was the underpinning data.
It's talking about that's the secondary data use.
Has there been a decision about that?
Okay, the secondary data use.
Consumer
Yep, good question. I was hoping no one would ask it. It was supposed to be, the framework was supposed to be released this week, but because it was budget week, it hasn't been announced. The secondary data framework is going to be announced prior to the opt-out date, and we didn't develop it. It had nothing to do with the agency. It was the Department of Health that have developed it, but the agency is going to have to implement the framework. And in fact, there is an opportunity to, it's not on the consumer portal, it's been hidden, but it's been developed. People will be able to opt out of their data being used. So there will be something on the consumer portal where you can tick. I can't show you because it's hidden, but it's been developed in preparation for the release of the framework. I personally don't think any data will be used for at least 18 months to 2 years. So that's how long it's going to take to implement a framework and the governance that sits with it to ensure that the data is used correctly. So, but the framework itself, I haven't seen it and I haven't got any information about it. And when it is released, there will be a whole lot of communications that will come out from the agency telling people more about it. Absolutely. Yeah, or for health system planning and all those sort of things. That's what, and researchers are, going to be knocking on the door to use this information. It will all be de-identified, but it is important that people are informed and that sort of thing. But there will be an option to tick to not be involved. So that's the protection. And as I said, we have built it, but because it hasn't been released. So yes, that will be. They were expecting it yesterday or today, so it's quite close. None of us have kind of seen it because it's coming from the Department of Health, but we do have to implement it. So just so that you're aware, and I can't really tell you anything else because I don't know, but I know that there will be an enormous amount of communications around it because it'll be a bit like the census, I suspect, when it's picked up by the press about the fact that everyone will be able to look at everything. Exactly. But do bear in mind that people will have an option not to be involved, and I think that's important that you know. I have no clue what the press are going to do. I mean, they just released a data thing for the banks and it didn't get any press, even though we're in the middle of a banking inquiry that all the major 4 banks are going to share all your information into a database. Not a dicky bird, honestly. Don't we care about our financial data? I do. I don't care about my health, but my finance. Okay, so oh yes, so we've just talked about these. Is there any other questions about that? No? Everyone, because secondary data use, the consultation period was very short and there was quite a bit of criticism about that as well, particularly from the Indigenous community, because they weren't consulted hardly at all, and they get researched a lot and they're a bit over some of those things. So there was some criticism, but it was a Department of Health, not an agency thing. There's the notifiable breach, written policies. So yeah, you need to do written policies. You can. These slides are going up on the website. So if you need a policy, we've got one there for you, or speak to the PHNs to get a template. I'm just conscious of the time, and we need to keep going. Emergency access. I think if you've got codes, this is the only time you need emergency access. There's a break glass situation. If you don't have a code, you don't need it. You can see everything. We've got a nice little brochure that the security people have written, and I think we don't have any on the stand, but we can post you some. Okay, at the moment, because it's opt-in, patients, when they register, give consent for you to upload and view their records in the provision of care. In the new world of opt-out, because they haven't opted out, the legislation says the same. Because they haven't opted out, you can still access their record and upload in the provision of their care. So the legislation changed during the opt-out trials that we're just redoing for this next opt-out period.
So we still need that, we still need to sit down and ask them to.
We say it is best practice for a shared health summary to talk to the patient about what's going up, but legally you actually don't have to do that. You could upload, but we're saying it's actually best practice to talk to the patient, particularly for the first shared health summary. You might not do it from then on because you're just changing something, and the expectation is that you're going to keep their shared health summary up to date, because the data is no good if it's out of date. That's one of the things that as we start getting more and more use, you know, you've got to keep the data up to, the information up to date.
Just an interesting point on that. About the patient coming to see you, and you've got all that information, and you're keeping it up to date. Your loyalty, the patient loyalty is such a not going to go around shopping as much. They know that you're going to be nominated GP to curate and maintain their share also. So actually there's another benefit that people can explore.
And where it had the exception.
Oh yeah.
5, is that illegal?
In New South Wales. New South Wales only.
Where do you find that bit of information?
In the privacy legislation.
On your...
I think we're writing something about this. It'll be on our website.
So will it be in the policy that you say is available?
No.
The practice policy does separate.
Yeah. I'll send it to you.
The consent you're talking about is considered best practice on that first upload of a shared health summary.
Yeah.
Is that meant to be written consent, or can it be?
No, verbal. No, it's absolutely, no.
You don't have to actually ask for consent. It's just
It's
a good practice. So when I first time said, look, I noticed you got a record, I can create a health summary and upload it. You know, I'm not getting
Yeah, I know
consent.
our practice is taking the stance that we want to go with best practice that is recommended, that we'll get consent on that first upload of shared health summary. But it just has to be verbal and
Yeah.
written into the
No,
notes.
hang on, no, you still, it's not consent. All I'm doing is, I don't have to consent. I could easily upload it without even getting, I've got implied consent by having the record available, and I'm connected, and you're in my care, I've got a shared health summary, I could just not say anything. I'm just saying it's just courtesy, customer service, which is, hey, I've got my health record, I'm going to curate a health summary. In fact, I use it and actually show them. Now, just double check, that's your allergy, that's this, that, yeah, that's all good. I'm now going to you're just telling them what you're doing, you're not asking them for consent. They can stop you and say, oh, I actually don't upload it. Well, that's
Essentially,
okay.
you are asking for consent, but you tell
Yeah.
them what you're about to do,
Exactly,
asking if
yeah.
it's okay. So
No.
consent.
Well,
Yeah, it is,
sort of
yeah.
okay,
It's a verbal agreement.
That's right.
That you're happy for them.
Yeah, and I might have stuff there and say, look, that's not relevant to my health anymore. Leave it in your system, but don't upload it.
So really, it is a consent conversation, and then you document it in your clinical notes.
All I'm saying is legislation doesn't actually state you've got to do
I know, but you're saying that it's best practice.
It's just
Yeah, that's right.
That's what I'm saying. Is an expectation that there's some kind of paperwork? Is it just written in clinical notes for that consent?
Written in clinical notes.
The clinical notes.
I just think it's what just terminology, consent versus maybe what you said is agreement.
Yeah.
I think it's that
It's just telling them what you're doing, and they can stop you anytime doing something. Like I'm
me, that's
about to put an
Yeah.
injection in you,
Yeah.
you say
Consent.
stop, it's hurting.
As a nurse, I know that as consent.
Yeah.
That's why
No, but that's why.
Okay, let's move on. I'm just conscious we want Christine to talk about what's going to happen with the consumers. So we talked about PAS and DI and managing consent and withdrawal of consent, Medico Legal. They've changed the penalties. They've upped them a little bit this year. I suppose the value of the dollar's gone down, so they've upped it to 126,000, increased by 6,000 this year, and 630 for organisations if you're breaching any of the penalties for misusing information, selling it to the papers, or hurting somebody by using their information inappropriately. We haven't had anyone do it. In fact, I think there's been 1 or 2 breaches at a very minor level of someone cleaning data or something and accidentally looking at somebody's record, and that's not a breach. That's just you're not maliciously doing anything. And as you know, some of the hospitals have sacked people who were looking at people's notes they shouldn't have been, because there's a record now of who's looking at what.
It's always been the case anyway.
Of course, I know. Yeah. So, and you need to take reasonable steps to upload accurate and up-to-date data. This is the most important. I'm just going to go through this and then I'm going to whip through these so Christine can have a go, because I think we need to hear from her. And we've talked about, just quickly, you're going to get a copy of these. So these are what the patients can do. We've talked about all of those, but here I've just shown you how to do it. So when you get these, have a look at this, and you can see when you go onto their privacy and access, and this then just shows you through. So you can get an SMS every time someone, or the first time an organisation looks at your information. I was sitting with Katrina Otto once, several times in the past few years, but she got an SMS from her GP saying her GP had uploaded a shared health summary, and we're in Melbourne. She lives in Sydney.
Is this on your app?
No, you have to go into, you've got to go onto your consumer portal to do these. So this is how you help your patient to do it. We've got a nice little video I can put on, attached to here before I send it, that you can show the patients. Christine, I just let you come up and do your things. So you've all got out of doing the workshop, by the way. You can thank all your colleagues for asking plenty of questions.
Thank you very much. Hello everyone, my name's Christine Bain. I'm basically the Communications Manager for Queensland for My Health Record, and basically I've been appointed to oversee all the Queensland communications, and my counterparts have also been appointed in each state, and I work for a primary health network, so I've been with Gold Coast Primary Health Network for a number of years, and before that the old Medicare local days. And basically I will work with all my counterparts across the state in Queensland, looking at communication strategies to basically raise consumer awareness, and so do my colleagues in other states. So the whole point, I guess, of that is to make sure that all of our engagement, all of our advertising, all of our consumer activities are completely local and focused in local areas and completely relevant for the target audiences. So, first slide. So basically, our objective is to pretty much tell 100% of the population, if we can, that they basically will have a My Health record created for them unless they choose not to have one. And basically that the way that we're going to achieve that is through, it's a very comprehensive, wide-reaching engagement and very targeted campaign. So basically we've got a number of target groups, and with these target groups, we have very specific campaigns for each of them. So obviously general public, there's a whole lot of wide-ranging strategies I'll talk about in a minute, but then we've also broken a lot of our planning up into specific groups. So as you can see from those, Aboriginal and Torres Strait Islander, there's a whole lot of work happening in that field state by state and also at a national level to make sure that obviously Aboriginal and Torres Strait Island people are engaged. As you can see from the list, older Australians, like I said, there's a whole lot of very targeted and specific strategies relating to those groups. And basically one of the key, I suppose, pillars of our engagement activities is through community engagement. So in every PHN, pretty much across the board, there are engagement staff that basically are going into the community as we speak, and they are basically going and talking to your Rotary clubs or your Probus groups or some of your health organisations, or they're going to local events and things like that. When the opt-out dates are announced, during that window, a lot of these activities will be ramped up even further. Some of the PHNs are going to be attending maybe 5 to 8 events a week. It's going to be, and potentially, you know, going to your local shows or your trade shows, or it's going to be a really intensive time, and that grassroots engagement is going to be very important. And as I said, it will reach literally hundreds of thousands of people. And in all the plans, we've identified a number of those events. If there's other events that you, for example, identify that we should be at in your local communities, then by all means contact your PHN and let them know that you think that they should be attending this event or that event. And I'm talking very much the consumer side here. So again, if you see any emerging needs, then we're very happy to respond. And as I mentioned here, it's service clubs, sporting clubs, health groups, consumer groups, support groups. Local MPs and local councillors are also being contacted. A lot of them have events or they put newsletters out in the community. We have bipartisan support for this program, so obviously any way that we can reach the community and engage with them is really important for us. So we're looking at a range of different avenues to do so. One of the things I'm doing straight after this meeting is I'm meeting a peak health group. Basically what I'm doing at the moment is I'm meeting a number of the statewide health organisational peak bodies and looking at ways that we can get our messages out through them. Some of them, one of the groups I met last week, they do newsletters to 110,000 of their patients, for example. And so collectively, I'm meeting roughly about 50 peaks in the next month, and by meeting with them and working at how we can communicate through them, and it will be a mixture of things. It will basically be a lot of them have regional staff and regional events, or they have obviously patients coming to forums or information sessions. They might be able to do a bit of education for us, obviously through their newsletters, through their online channels, through website information, through linking with us on social media. There's a whole lot of things that some of these peak bodies can do to assist us. So basically that's kind of what we're all working on collectively at a state and regional and national level. On top of all the grassroots and the engagement, we also are doing an advertising strategy. All of that is still being finalised at the moment, so nothing is completely set in stone yet. But basically what's happened is that, as I mentioned, a lot of this is local. We're looking at a grassroots engagement campaign. So each PHN has provided me with feedback, for example, in Queensland, and said, these are the best ways that we can engage and reach our communities. These advertising options are the best ways that we can, for any sort of paid media or paid advertising, that we can reach our audiences. And so I've taken that, put it into a plan, obviously looked at other strategies we think might work as well, and basically every state will have a different plan for how they engage and what advertising mechanisms that they use. So they're not all going to be the same, but again, it's going to be targeted and very specific. But it could include, and I'm not going to say it will include, but it could include things like your radios. One of the things that I'm really keen on doing is something with the community radio stations. Some of them we can do sponsorship and all sorts of things. Some of them, for example, have multicultural channels to a range of languages. Some of them do very specific seniors. One station I was chatting to, they actually broadcast in a number of nursing homes, for example. So there's a whole lot of things when you start drilling down into the reach of some of these organisations. It's actually huge. So as I mentioned there, I think we've just got a few things on there around cinema, transport practice, potential GP practices. There's a whole lot of things. Publications are going to be very big for us as well. There's a number of targeted publications that we're looking at that reach. There's one I'm working on at the moment in the senior space just for Queensland that will go out to over, I think they produced nearly 100,000 copies of their publication, and that's read by somewhere by 200,000 or 300,000 seniors, for example. So there's a number of different strategies, and with a lot of these too, I know Heather talked before about local stories. We're trying to put local people in some of these stories, and specifically people who meet some of our target groups. So if it's a story for seniors, then for example, we're using a local champion who happens to be a senior and who's got an interesting story to tell. So it's very relatable and also very local for those audiences. And as I mentioned before, we've got our very targeted strategies for our specific target groups as well, like people with chronic conditions, for example. And then I mentioned before briefly, we also have community champions. So every primary health network has identified people on the ground that are happy to promote My Health Record to their cohorts, and they can be people who might be consumers on advisory panels, they could be former patients. If you've got people that you think have got a good story to tell, again, let your PHN know, because that's all really useful, and those champions are going to be able to come to some of our events and things like that. Some of our champions on the Gold Coast, for example, are some consumers that are able to go to events like this and be able to sort of talk from a consumer perspective about how My Health Record will sort of work for them, basically. And then basically we also have some media strategies. So obviously during the time frame we're looking at regular media opportunities. We want to try and get out there, you know, do regular radio, television stories and things like that. A lot of this stuff is really going to be ramped up during the opt-out period. So what's probably happening right now is there's a lot of stuff at the grassroots engagement that's happening. They will be ramped up, and all of this stuff, of course, the media buy and any of this sort of media will really be ramped up during the opt-out. And as we mentioned here, basically, we're looking at press club briefings, local media stories. Again, we come back to local. And the PHNs are also going to be looking at identifying some local media stories to get on their local television channel and things like that. The other thing is that we also have massive social media strategy that will be occurring as well. There will basically be a Facebook, Twitter, Instagram campaign. We have local coordinators in each state as well that are targeting on social media and working with the local PHN. So again, while there's going to be some national messages, there'll also be a lot of room for the local content, and hopefully with all of our peaks and with different organisations, we can share a lot of that information and a lot of the stories. A lot of them are also happy to put information on their website for us and things like that. There will be a little bit of paid advertising, and we'll probably be using some social media influencers as well, just to help drive traffic to the website for more information. So any questions?